I would like to welcome Okay, good evening, ladies and gentlemen. I'm Dr. Teng Wei Woon from Hospital Queen Elizabeth. I'm a general surgeon. I would like to welcome you all to our today's presentation, Thyroid nodules. Allow me to introduce our speaker of the day, Datin Dr. Rohamini, our consultant general surgeon. She is the head of surgical department, Hospital Queen Elizabeth, Sabah, and head of Sabah Surgical Service. She's my mentor since my housemanship. So without further ado, I would like to welcome Ms. Roha to deliver the presentation. Please feel free to ask your question in the comment box. And alright, Ms. Roha, the floor is yours.
Okay, thank you, Mr. Teng. Good evening and Assalamualaikum. I know everybody tired, but just please spare a bit of time to listen to our talk, monthly talk. Today's topic is thyroid nodule. Are we worried? Thyroid disorder has broad spectrum. There are several diseases that include in the thyroid disorder, but today I only will concentrate on thyroid nodule. So, are we worried if patient come to you with thyroid nodule? So, let's say in your clinic you see a patient, example 35 years old lady come with left thyroid swelling for 1 year duration. No other symptom other than the swelling, and it's painless. So what history do you want to ask more from the patient? What are the differential diagnoses that you think of? Eventually, do you have to think whether this nodule, are you worried about this nodule or not? Worried means, are you thinking of malignancy? Do you need to investigate the nodule, or just tell the patient that this is a thyroid nodule, it's common condition, so you don't have to investigate? So a thyroid nodule or goiter is just a discrete swelling at the thyroid gland, and it can be separated from the, by examination and by ultrasound, the nodule can be separated from the entire thyroid gland. So, and this nodule can be noticed by the patient itself, or can be examined by doctors. And another patient also might present with thyroid nodule which not palpable, but only detected during routine ultrasound neck for, or CT scan for some other disease. And the incidence of the thyroid nodule in Malaysia, there is one study, multi-center study done in Malaysia. It shows that the incidence of thyroid nodule about 5% in women, and slightly lower in men, about 1%. And the incidence of this thyroid nodule increase if you do routine ultrasound, and the incidence also increase as the age increase. So, are you worried, patient with thyroid nodule? The answer, of course, yes. Yes, because one of the causes of thyroid nodule is thyroid cancer, and we are lucky, or fortunately, among all the thyroid nodule, only 5 to 10% are thyroid cancer, and the remaining are benign thyroid nodule. And even though the rest are benign, but you have to investigate. You cannot say, if after you see a patient in the clinic, you just say, oh, it's benign, and you don't have to investigate. Of course, you have to investigate. Any patient come to you with a thyroid nodule. So basically, when you see a patient in clinic, can you differentiate the patient by looking, or by asking the patient history, by looking, can you differentiate the nodule, whether it's thyroid cancer, looks like thyroid cancer, or just benign nodule? The answer is yes and no. It's yes because Of course, after get the history and examination, some thyroid cancer you can differentiate from the benign condition, but most thyroid cancer, if the patient come early to you, the nodule almost like other benign condition, and the patient normally is young, maybe 20, 30 years old, and they just present with thyroid nodule without other symptom. If just looking, you cannot differentiate it from the cancer, so you have to investigate. That's why the answer yes and no. So this is from Sabah Cancer Registry report 2012 to 2016, which was published recently. Thyroid cancer is number 8 among female. It's not that very common, but still among top 10 is number 8 cancer. So how do you divide if patient come to you with thyroid nodule, how do you divide? Easy, if you see a patient like the patient just now came to your clinic, if you see the patient, how do you divide? If most patients come with thyroid swelling, so you can divide the thyroid condition or thyroid nodule into 3 big groups, which are the diffuse thyroid swelling, or multinodular swelling, or solitary. I always ask my houseman or MO, among all those 3, which nodule that you worried about? So the answer is solitary. Why? Because solitary thyroid nodule, one of the causes is thyroid cancer. So if any patient come to you with solitary thyroid nodule, definitely you have to investigate further. So there are few causes of these 3 different groups. If diffuse thyroid swelling or thyroid nodule, you can divide into toxic and non-toxic. Non-toxic example, puberty, patient pregnancy, in physiological goiter, but with in common diffuse toxic swelling, the common cause is grave disease or thyroiditis. And solitary thyroid nodule, there are several causes. Most that you worried is thyroid cancer. Other causes is thyroid adenoma, thyroid cyst, or thyroiditis. Even patient with multinodular goiter can present with solitary. By presentation, patient present with solitary, but after further investigation, after ultrasound, and actually noted patient has multinodular goiter. Even solitary thyroid swelling also can be toxic or non-toxic. And thyroid cancer normally euthyroid or non-toxic. Multinodular goiter is on its own diagnosis. It can be toxic or non-toxic also. So any patient come to your clinic, they will present, most common they will present painless thyroid swelling. So other symptom, when you ask the patient, you have to group the symptom into the swelling itself, or assess whether the patient has hypo or hyperthyroidism symptoms, or any compression symptom, infiltrative symptom such as hoarseness of voice. So if any patient come to your clinic with solitary thyroid swelling together with hoarseness of voice, you have to make a diagnosis of thyroid cancer until it's proven otherwise. Or any patient come with solitary thyroid swelling together with lymph node, it is thyroid cancer until proven otherwise. And other patient might present as incidental loma, means they don't have any symptom, they did not even notice they have thyroid swelling, but when their friends saw their neck and mentioned that, oh, looks like there is a thyroid swelling, or patient went for any imaging and noted to have a thyroid nodule. So among all those symptoms, actually when you see a patient in clinic, there are patients that there are history that you might, if you see a patient, you might suspect this patient might have thyroid cancer based on these symptoms. If male patient come with thyroid swelling, you have to suspect. Even though male with thyroid swelling is very rare, the incident, but if they have a thyroid swelling, you have to suspect thyroid cancer. Or a very young patient, less than 20 years old, or very elderly patient, more than 60 years old, presented with thyroid swelling, you have to suspect, or especially solitary thyroid nodule. And some patient might present with skin changes, skin infiltration, or if there is swelling, of course patient will touch the swelling and they notice that the swelling is not mobile and very hard. Or patient with previous history of thyroid swelling or previous radiation to the neck for some other reason, family history with thyroid cancer, so you have to suspect. And some patient, if they might present with symptom of metastasis like lymph node swelling. So patient might come to you, doctor, I have this neck swelling for the past 1 year, but since few months ago I noticed another swelling beside the nodule, and when you examine, patient has lymph node, so then you must suspect thyroid cancer. And this thyroid cancer, they like to spread to flat bone like sternum, scapula, or skull. So if any patient come to you with scalp swelling, you don't biopsy or you don't aspirate the scalp swelling. You have to suspect, you have to investigate for thyroid cancer before you can do something to the swelling. This is example of patient with thyroid cancer, but very advanced. This patient normally present with long-standing thyroid swelling, and it's increased in size and infiltrate the skin for certain duration. So when you examine patient with any thyroid swelling, any thyroid disease, so you always initially you talk to the patient. If patient has hoarseness of voice, you have to suspect. So patient might present with diffuse, multinodular, or solitary. And if patient has hyperthyroidism, they might have a thyroid eye sign. And if the nodule is fixed, hard, skin changes, and not mobile, so you have to suspect thyroid cancer together with the lymph node. So after you get the history, examine the patient, then you should be able to make a diagnosis. So let's say patient has diffuse thyroid swelling, the diagnosis doesn't stop there. So you have to know what is the cause of diffuse thyroid swelling. So example, Graves' disease, or if not toxic, is a physiological diffuse thyroid swelling. So if patient has non-toxic solitary thyroid nodule, so you have to proceed with the diagnosis and suspect thyroid cancer or thyroid cyst or prominent nodule or multinodular goiter, as I mentioned earlier. Or if patient has multiple nodule, your diagnosis is multinodular goiter. So in KK, if patient has hyperthyroidism or thyrotoxicosis, you can refer patient to endocrine clinic, medical endocrine clinic in Queen 2. But if patient has thyroid nodule, in KK you have the choice to refer to us in general surgery clinic in Queen or breast endocrine surgery clinic in Queen 2. So we assess patient, you can refer to both hospital. And if you from Keningau or Sandakan, Tawau, you can refer, if patient with thyroid nodule, you can refer the patient to surgical department in each district. So assessment of the thyroid nodule almost similar to breast. You do triple assessment, which is history, examination, ultrasound, or imaging, which is ultrasound neck, and biopsy. Ultrasound thyroid is the gold standard investigation of thyroid nodule. So if any patient come with thyroid swelling, you have to do ultrasound. And other investigation is thyroid function test consists of TSH and T4. And if patient TSH is low, means patient is hyperthyroid, you have to do T3. And you need to do indirect laryngoscopy if patient has hoarseness of voice or if patient need to proceed with the operation. So as I mentioned, ultrasound neck is the gold standard of the examination, investigation of the thyroid nodule. The advantage of thyroid ultrasound neck is it can assess the character of the nodule, whether it's solid or cystic or present of lymph node. However, the ultrasound neck is operator dependent, so it's sometimes the report slightly different, and there are features on the ultrasound neck which can help you doctors to diagnose thyroid cancer. And ultrasound neck will be done in two planes, transverse and longitudinal plane, and there are few features on the ultrasound which suggestive of thyroid cancer. This example, if the margin is irregular, you have to suspect thyroid cancer. If the tumor infiltrate the capsule, so it's a malignant features. If normally the normal benign thyroid nodule, it has a halo region around the nodule. However, in the cancer, in malignant thyroid swelling, it absent because of infiltration of the capsule. And thyroid cancer, you suspect thyroid cancer if the echogenicity is become hypoechoic, is a hypoechoic lesion. And if the size is the height and width ratio is more than 1, means the nodule is taller than the width, so you have to suspect cancer, almost similar like breast cancer. And the presence of vascularity inside the nodule, we suspect cancer. Also presence of microcalcification. And as I mentioned earlier on, lymph node, a patient with nodule with lymph node, you have to suspect cancer. And thyroid cyst also, if patient has complete cyst, is simple, but however, if present of solid cystic, which is called complex cyst, you have to suspect thyroid cancer. So American College of Radiology made scoring system in which they collect all they assess the thyroid nodule based on the 5 features, based on the margin, consistency, the shape of the nodule, and they collect a point, so to form, and this scoring system called TIRADS. So they collect a point, so if patient has a lower point, they group into TIRADS 1, and patient has higher point, they group into TIRADS 5. The different one is patient with normal thyroid gland or benign will has lower TIRADS number, TIRADS 1 and 2, whereas the patient has suspicious thyroid cancer will have TIRADS 3 to 5. TIRADS 6 actually patient already has confirmed to have a biopsy proven to have cancer. So this TIRADS scoring or result useful, acceptable throughout the country or throughout the world, and everybody agree to use this result or report or scoring. This TIRAD will help us to decide which nodule has higher risk of cancer, and if the patient has TIRADS 3 and above, this patient might need to have or might need to proceed with fine needle aspiration biopsy to confirm the cancer. And patient also might need CT scan. Not all patient you suspect thyroid cancer need CT scan. Only CT scan only need for huge goiter, which can be benign, huge multinodular goiter. If you suspect thyroid cancer, which is huge. If patient you small nodule and you suspect thyroid cancer, ultrasound only is adequate. This is example of patient with advanced thyroid cancer, huge nodule, fixed with skin changes and dilated vessel. So fine needle aspiration cytology or biopsy is the only way for us to confirm the diagnosis. Other than ultrasound, we need to confirm the diagnosis of cancer by doing cytology. So in previously surgical team, surgical MO, surgeon do our own FNSC, but in Queen last few years we have FNSC clinic run by our pathology MO. So we can, if we suspect patient with suspect thyroid cancer and need FNSC, we can just refer to FNSC clinic. And even district hospital also can refer for FNSC clinic. So all patient with solitary thyroid nodule need to have FNSC. But if patient has multiple nodule or diffuse thyroid swelling, doesn't need FNSC unless patient with multinodular goiter with prominent nodule. So you have to do FNSC of the prominent nodule because you suspect thyroid cancer. And this is the result of the FNSC result. Also they classify into Thai 1 to Thai 6 based on the result, and Thai 4, 5 and 6 you suspect cancer, or in Thai 5 is you suspect cancer, and Thai 6 is confirmed cancer. And for thyroid cancer divided into differentiated and undifferentiated. So for thyroid cancer, follicular thyroid cancer or medullary thyroid cancer, you can diagnose by FNSC, whereas is follicular thyroid cancer, you cannot diagnose by FNSC. The report only will come back as follicular neoplasm. So you have to do hemithyroidectomy for you to confirm if the tumor is thyroid cancer. And sometimes if the nodule is not palpable, but if on ultrasound the nodule suspicious, so you need ultrasound guided to do FNSC. So whereas for benign, for small nodule and the reported on ultrasound as benign, you don't have to do biopsy, you don't have to do FNSC. You can just do surveillance ultrasound for 6 to 12 month interval, and subsequently yearly or 2 yearly based on the ultrasound report. So once you make a diagnosis of the thyroid nodule, how do you manage the patient? How do you treat the patient? The treatment depends on the diagnosis what you made, whether diagnosis is thyroid cyst or thyroid cancer or multinodular goiter. So talk a bit on the thyroid cancer. As I mentioned earlier on, it's divided into differentiated or undifferentiated, or if the cancer arises from the parafollicular cell, it's called medullary thyroid cancer, or if other from the other type of thyroid cancer, lymphoma or sarcoma. So if patient has thyroid cancer, the treatment, once you diagnose, the treatment is total thyroidectomy. Remove the whole gland. If patient has lymph node metastasis, you have to confirm the lymph node metastasis by FNSC. If confirmed, then patient need to have modified radical neck dissection. If patient just present with thyroid swelling, So we will do total thyroidectomy. This is example of patient with had total thyroidectomy for thyroid cancer, and subsequently subsequent treatment for thyroid cancer is radioiodine ablation, and patient need to have higher dose of L-thyroxine for us to suppress the TSH. I will skip this. So patient need to have higher dose of thyroxine to suppress TSH, and radioiodine ablation. All differentiated thyroid carcinoma will need to go radioactive iodine ablation, and subsequently patient will need to have a whole body scan to assess any metastasis to other part of the body. And thyroid cancer, papillary thyroid cancer will spread through lymph node. So if patient with papillary thyroid cancer will have a lymph node metastasis, whereas follicular thyroid cancer will spread hematogenous to bloodstream, go to other organ, flat bone like scalp, sternum or scapula. I always ask my husband or MO what are the symptoms of the thyroid cancer. So they like to say loss of weight, loss of appetite. Thyroid cancer is slow growing tumor. They will not present with loss of weight or loss of appetite. They just like other patient, they will present with nodule. So the thyroid cancer, if you ask to choose any cancer in the body, you can choose thyroid cancer because slow growing, and thyroid cancer can be cured. Once if you come early to hospital, if patient come early to hospital, and if get treatment, patient can be cured. They can live long like other patient, provided the patient will go complete treatment, operation, radioiodine ablation, and TSH suppression. I will skip this. Okay. If we follow up patient with thyroid cancer, we will do regular history examination, thyroid function test, and make sure TSH suppressed, and we need to have serum thyroglobulin, but we don't do serum thyroglobulin to diagnose thyroid cancer. Serum thyroglobulin is to monitor after operation, and to know if serum thyroglobulin increase, so you might suspect patient might have recurrent thyroid cancer. That's about thyroid cancer. Other condition, other benign condition of thyroid nodule. Let's say patient has thyroid cyst. If patient has complete cyst, you can aspirate, and if after aspiration patient still has recurrent nodule, so you can do FNSC, but most of the time result will come back as thyroid cyst. So you only the indication for operation for thyroid cyst is recurrent cyst, or if you suspect patient has underlying thyroid cancer, in which patient has complex thyroid cyst. And if thyroid cyst causing neck compression also, is indicated for operation. If patient has colloid goiter, you can follow up the patient, and indication for operation for colloid goiter is for cosmetic reason. This example, patient with multinodular goiter. Multinodular goiter also is a benign condition. You can follow up the patient, but we only do total thyroidectomy if the swelling is huge, or on patient request for cosmetic reason. Otherwise, if patient with multinodular goiter, you try to delay the operation, especially if patient young or patient childbearing age, and the swelling, the nodule not so big, so you can delay the operation until and monitor, and if the swelling shows increase in size, then you can offer operation to the patient. But the problem with the multinodular goiter, you have to do operation, total thyroidectomy, remove entire gland, and patient need to take thyroxine for entire life. So before you decide to do total thyroidectomy for the patient, you have to make sure patient compliant to medication. Other thyroid condition like physiological goiter, you just treat conservative, don't have to do operation. If patient toxic diffuse goiter, Graves' disease, you can refer the patient to endocrine clinic. Most of the time they will give anti-thyroid drugs, and if fail medical treatment, there are options of radioiodine ablation for Graves' disease, or you can refer to surgeon for total thyroidectomy. If failed medical management, or patient has Graves' disease with a huge goiter or huge swelling. Okay, this is the algorithm for the thyroid nodule. Okay, so before I end my talk, take home message: any patient with solitary thyroid nodule, you have to investigate. So because some patient or most patient with solitary thyroid nodule, if the patient has thyroid cancer, you cannot differentiate by examination or by history. You cannot differentiate from any other thyroid swelling. So unless you do ultrasound and you do FNSC, then only you know whether that thyroid swelling is dangerous or not. And ultrasound is a gold standard imaging and should always followed by FNSC. As I mentioned earlier, thyroid cancer can be cured. So if you get thyroid cancer, if the patient get thyroid cancer, come to hospital very early, receive all the treatment, operation, radioiodine ablation, and suppress the TSH. Patient can be cured and can live long. Thank you. Actually, we have Malaysian CPG which was published in 2019, which can explain. You can refer all the treatment of thyroid disorder to the CPG, which include the thyroid nodule. Thank you.
Okay, very good presentation from Ms. Roha. Thank you, Ms. Roha. So we off for 2 minutes, and everyone are welcome to comment and ask any question in the comment slot. Thank you. So now we are back to our discussion. So Ms. Roha, we have a few questions here. So the first one, we are asked about when should we refer a thyroid nodule to you?
Okay, if you see a patient with thyroid nodule, you have to assess whether the patient has hyperthyroid or hypothyroidism. So if patient has hyperthyroidism or hypothyroidism, you have to all patients need to have a thyroid function test, and if found out that patient has hypothyroidism, at your clinic you can give the treatment. But especially if patient has a solitary thyroid nodule, definitely you need to do ultrasound for the patient. So ultrasound, you can order ultrasound from your clinic level and review the result. If the result of the ultrasound suspicious with the all features that I mentioned earlier, patient need to have FNSC or FNAB. So FNSC only can be done at hospital, either Queen or Queen 2 or any private hospital. So if patient with suspicious features on ultrasound, so you have to refer to us. If patient with solitary thyroid nodule and the ultrasound finding in favor of benign like cyst or looks like colloid nodule or looks like adenoma, you can follow up the patient with serial ultrasound. Means you can repeat ultrasound after 6 months or after 1 year. If the ultrasound report not much changes, subsequently you can follow up with yearly ultrasound. But if the ultrasound, if patient has cyst and the size is more than 2 centimeter, you can refer to us. We can do aspiration of the thyroid cyst. If the size less than 2 centimeter, you can continue follow up in your clinic. Okay.
So the next question we have is when do we need surgery for benign thyroid nodule?
Okay, benign thyroid nodules, of course, some condition you need to do FNSC like thyroid adenoma. You will not know the diagnosis until you do FNSC. So like if example patient with thyroid cyst, as I mentioned earlier on, if the size less than 2 centimeter, no need operation. If the size is more than 2 centimeter and on follow up is increased in size, you can refer to us and then we will do operation hemithyroidectomy. If patient has multinodular goiter, depends on the size and depends on the patient request. If multinodular goiter, you can follow up the patient. But if the size big and cosmetically disfigure and patient request for operation, you can refer to us. We will do total thyroidectomy. So as general benign thyroid nodule, if confirmed, you can continue follow up.
So okay, thank you, Ms. Roha. And I think that will conclude our presentation for today. Thank you everyone for participating and good evening for everyone.
Thank you.